Thank you very much. Welcome, everybody. I'm so excited to get to talk about pain management. This is really one of my passions when it comes to our dental patients. The days of animals not feeling pain or thinking they don't feel pain are long gone. And if you've ever had dental pain, you know how painful it is. So we really want to make sure that our patients are getting decent pain management and things that actually work to keep them comfortable during and after procedures. So we're going to talk a little bit. I've got anesthesia in here. You know, anytime we're doing a dental procedure, we're going to have anesthesia, and that's just the absence or loss of sensation. And when we're doing a dental procedure of any type, we should have them at a surgical plane where the muscle we have muscle relaxation as well as analgesia on board. And that is just the absence of pain. Now, when we look at doing dental procedures on our patients, we really need to make sure that we're doing balanced anesthesia. And that is, you know, kind of the key word now is multimodal. And that means we're using multiple different drugs in order to, you know, hit different places along the pathway. And what's nice about this is that it minimizes the drug's effect, but it also maximizes their benefit. And we need to make sure we're tailoring those to the specific animal. And it's really important that we use pre-medication and sedation drugs to not only reduce the patient's anxiety, but kind of get them at that right state before they enter anesthesia. Now, when it looks to what we're going to do with preemptive analgesia, we want to make sure we're giving these drugs prior to the procedure. These are going to be our typical options are going to be midazolam, excuse me, I can't pronounce words today, diazepam, acepromazine, dexametastomidine. These are going to have a more profound effect when they're used alongside any type of opioid. Now, I still have on here the anticholinergic. You know, there's some debate right now if we still should be using an anticholinergic such as atropine or glycopropionate. But, you know, or glyco, excuse me. But, you know, I think sometimes that's a doctor's decision. So when we're looking at opioids, we need to make sure we realize that, you know, what receptors they're going to provide the analgesia. And this is the choice of the veterinarian. We need to understand all the different side effects those opioids might have, as well as constantly monitoring any patient who is under anesthesia and on an opioid. This is my personal opinion, some of the poor choices, because I don't think they offer very good pain control, are going to be butorphanol. It's not very strong at all, and it actually can block some of the other opioids effects. So, you know, Torb is just one of those things that I'm just not a big fan of anymore. I just don't think it does justice to pain management. Another one that I used for years when I was in practice is buprenorphine. And we know that, you know, buprenorphine can actually block other opioid effects also. Now, there is one benefit. We'll talk a little bit about this when we get into the blocks. But when we look at buprenorphine, it can actually increase the longevity of a regional nerve block or a dental nerve block. So we'll talk about that. So it does have some purposes. Other good choices for severe pain are going to be hydromorphone, erythemia, and these hydromorphone can prevent hypothermia in dysphoria in cats. Methadone is another one, morphine, allergic reactions. We might see that in some of the cats, and fentanyl CRIs also work really well. Now, when we're looking at pure opioids, they can be reversed with Nociception. I'm going to check something, guys, really quick. I am just double checking that I have the right presentation up. Something isn't clicking with me. Hold on just a second. Oh, I'm okay. All right, just making sure. All right. So when we look at dental patients, primarily, we are still, in most practices, not probably recommending or prescribing a dental cleaning and dental procedure, cohat, whatever you want to call it, to be really truly preventative. And a lot of times we're waiting till we see where we see stage 3 or stage 4 periodontal disease. And these are going to be more common in our older patients. A lot of times it's more common in our smaller patients, just because of the nature of the smaller dogs having more periodontal disease present. Sometimes these animals, we've let that procedure go and they have some kind of a secondary something else going on with them, you know, a comorbidity, maybe it's diabetes, overweight, heart disease, kidney issues, whatever. And the problem is we also still consider dentistry kind of as an elective procedure. And we really have to get over that and consider it being something that is, if it's done correctly, it is the same type of prevention we would have with any of the vaccines we use, with heartworm prevention, you know, flea and tick prevention to prevent some of the tick-borne illnesses and those kinds of things. We just don't still, in many cases, don't put enough emphasis on patient safety when it comes to anesthesia, especially in dental procedures. You know, there was the day back when I started a long time ago that the dental procedures were done on a table in the back of the clinic. You were back there by yourself, monitoring anesthesia and cleaning the teeth all at the same time. And that really isn't a good setup. You know, we're really concentrating on one thing when we're cleaning the mouth. And a lot of times I would say, I don't really know anything's going wrong until the tongue is blue. So I didn't want to have to stop every 3 to 5 minutes to take vitals. So we wanted to make sure that our patients were being properly monitored and had a dedicated anesthetist. So we can also minimize risks when it comes to our dental patients. And that's going to be, you know, running that blood work. I call it surgical safety blood work. It's just a little bit more warm and fuzzy name than pre-anesthetic blood work, making sure we don't have any underlying issues that we're not aware of. If we have that elderly patient or that geriatric patient, maybe we run an ECG on them, making sure that there's nothing going on there. We definitely need to make sure we're doing a full physical examination, and we have to customize our anesthesia protocols. We can't do the, you know, everybody gets cat val. Those days are gone. We really have to look at the patient, all of the things that are going on with that patient, and decide what is going to be the best anesthetic protocol for that specific animal. And then again, as I said in the last slide, dedicated anesthetist, someone who is standing there monitoring the patient. And I don't mean hooking them up to a monitor. The monitors are great, okay, but they do run a little bit behind what's actually happening in the patient. And sometimes they can give off an alarm and everybody gets kind of tired of it and you shut the alarm off. So you're really not paying attention to them. Having someone there, you know, with this kind of old-fashioned anesthetic monitoring technique called a stethoscope and laying your hands on them every once in a while is actually going to be the best to keep that patient as healthy as long as possible. Now, when it comes to any type of dental procedure, we know they're going to be painful, okay? And we know that pain is inevitable, but suffering is optional. So let's talk about what we can do to prevent the pain. Well, we know what pain is. I don't need to read this to you, but it's an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So we all know what pain is. We've all had pain in our lives, and we've all seen it in animals. We're going to talk a little bit about the nociception, and that's the kind of the pathway that animals and us feel pain. So we know that the anatomical structures and the neurophysiological mechanisms in animals are very much the same as what we have in our bodies. So we know that if I you know, cut myself, it's going to be painful. If a patient cuts themselves, we know it's going to be painful for them. So we have to think about, is this going to be painful to me? If somebody did it to me, we need to think about that with our patients. So there's 3 distinct physiological processes when it comes to nociception, and that's going to be transduction, transmission, and modulation. Now, transduction is basically that's that what happens when you first have the injury. It's that translation of the physical energy into electrical activity at the peripheral nociceptors. I can't talk today. that word right there, nociceptors. And we have things, it can be mechanical, it could be chemical, it can be thermal. So if you have a laceration or a cut or you stub your toe, that's mechanical. Chemical, I always say that if you've ever dug through a instrument tub full of cold sterile solution and you find out you have a cut on your finger, you find that really quick because it hurts like crazy, that's a chemical. All right, or you get burned by an acid. Now thermal obviously would be, touching something that's too hot. And we have all these sensory nerve endings, and that's what's being affected by transduction. Transmission is going to be the movement of the nerve impulses through the nervous system. So we stub our toe, okay, and we have that instant gut-wrenching, almost make you want to vomit pain. Okay, that's the A delta fibers reacting. That's that, oh my God, that hurt kind of attitude. And then after that kind of subsides a little bit, the C fibers take over. And that's when you have that dull throb that we have when we have an injury. So we kind of have two different levels of transmission. And then we have modulation, and this is going through the spinal column. So we've cut our finger, it's gone through all our little nerve endings, and now it's going up through our spinal column to when we actually feel it, which is perception. I don't know if you heard him, but he screamed ouch really loud. This is the result of the successful transduction, transmission, and modulation. Now, we just went through those pathways, but just to reiterate it, transduction, site of injury, transmission, all those sensory nerves, all those little synapses are happening, and it's transmitting it to the spinal column. Modulation goes up through the spinal column to the cerebral cortex, where we actually have the perception of pain. Now, we know when we have pain that there are pathological problems. There's consequences to pain. We know that pain can be actually pathologic in itself. And that means that an animal who is painful may be at a greater risk for infection. They aren't going to have the wound healing we'd like to see. It's not going to be as fast as we'd like to see. These guys are not going to want to eat or drink. And nutrients and nutrition is really key to making sure that our pets heal well and recover well. A lot of times it's also immobilization. These pets don't want to move. They know if they move, it hurts, right? If you've ever had any type of surgical procedure yourself, one of the first things they do with you after you're out of surgery and in recovery and out of recovery is get you up and moving. Okay, we know that moving is important. Now, patients can also have altered sleep patterns. Maybe they're sleeping all the time or they can't sleep at all. And even altered behavior patterns. And I have seen this more times than I can even think about, but where you either have the sweetest dog in the world comes in, some kind of procedure is done to them, and they suddenly become kind of the spawn of Satan. They're just, or you have that very fractious animal that comes in, and after the procedure, they're just going to lay low. A lot of that might be more behavioral, emotional kind of things, but it is a reaction to the pain. Now we know, anybody who's done surgery knows that we're going to have physiological signs of pain. So you're doing an ovarian hysterectomy, you're getting ready to, do a little tugging on some ligaments, and the first thing that happens is your patient's blood pressure increases as well as their heart rate. They may even become a little bit blanched in their mucous membranes, and they're going to start breathing a little bit heavier because they're feeling that pain, and those are physiological signs to the pain they're feeling. Now, dogs and cats react a little bit different to pain, and we really have to know and watch how to watch our animals to determine when they're painful. So dogs will sometimes whine or whimper when they're painful. Again, they could either be very timid or very aggressive, but a dog will actually just kind of sit there and stare off into space. And they're usually pretty restless. They can't get comfortable. They're kind of in their kennels and they're turning and moving around, and they just can't get comfortable because they're in so much pain. Now a cat will purr growl or groom. And I tell you, I have seen cats with fractured pelvises that are just, you know, a jigsaw puzzle, and the cat is purring. All right. I've talked to clients who did not believe me that their pet was painful from tooth resorption because it kept purring the whole time. Purring is a way for that cat to calm themselves down. Now, we all know that a cat who's painful is probably going to hide. All right, they're going to be the ones, they come home from a dental procedure, you call for a checkup a few days after, or, you know, a day or so after the dental procedure, and the owner's going, well, I think he's fine. I really haven't seen him for 3 days. So that animal is hiding somewhere because he's painful. If the cat is maybe in your clinic and you're watching him, they're going to probably squint instead of staring off into space. And a cat will usually be the ones who are pretty much immobile. They don't want to move. They hurt. As I said, we're going to have reduced appetite, food intake. They may have altered voiding behaviors. Maybe they're going to mess in their kennels that they hadn't done before, or they just don't want to groom themselves. We really need to know how to assess pain when we're talking about this with our patients. We need to know what's kind of normal for that patient if we can. And that means we're going to kind of watch them from a distance before the procedure, if at all possible. And we're going to kind of see how they are before anybody's with them, as far as a veterinary professional, and then how they react once we have that evaluation with the veterinary professional. And we should be recording these findings. Now, it's not always possible to see them before a procedure, but we want to do that if we at all can. And we can use a lot of assessment tools, and there's a lot available. I just have 2 here. These are both from Colorado State University. If you just type in pain scales, veterinary pain scales, you'll get a plethora of options available. But I recommend using something like this in your practice, and make sure everybody in your practice is trained on how to evaluate it, because, you know, we don't want someone who's going to say, oh, that dog's at a stage 1, and everybody else is going, no, that's a 3. Okay, so make sure everybody's kind of gone through some training on how to evaluate the patients. But this one is one for dogs, and then of course they also have one for cats. And in addition to this, we now have some of these grimace scales that are out there, and I think they're pretty cool. They're like, you know, they have like the face of a cat, and it's like, okay, there's three facial expressions. They actually have one for like donkeys, and I think they're getting them for almost every species. So if you look at the grimace scale, it's kind of like if you go to the emergency room or to the doctors, especially with like little children, they'll say, okay, look at the smiley face and tell me where you are right now, you know? So it's kind of like that in some ways. Now, the benefits of pain management in my book far outweigh the risks that are associated with the administration. Yes, placing a dental nerve block can be risky. However, I just really feel that the pain that that patient isn't feeling is much more important. And we have to, you know, kind of outweigh the risks. So when we use pain management, we want to make sure that we are using multimodal analgesia. Okay, that means we're going to use 1 or 2 different drugs and different techniques along the way, because we're trying to stop those steps of that pathway. Okay, so we might do a local that's going to kind of stop at that, right at that level of transduction, and we're not going to want to go through transmission and modulation. We really want to prevent inflammation. Inflammation is redness, swelling, you know, heat, but it is also leads to pain, as well as windup. And windup is when we have a patient who we don't give analgesia to, and then by the time we finally give them something, what we're giving doesn't have any efficacy anymore, or has very little efficacy, so we're having to give more. So for instance, in my situation, I get migraines, and sometimes I tend to put off taking something because I'm like, oh, it's going to feel better in a couple minutes or a couple hours. And I put off taking something. And then by the time I finally give in and take something for it, I have to take twice as much as I would have if I had taken it at the first initial signs that I was getting a migraine. So just kind of be aware that we want to give them pain management so that we don't get into that windup. Again, we can look at preemptive meds, opioids, alpha-2 antagonists, NSAIDs, epidurals, and I want to preface this by saying I am not an anesthesia person. I do what I can. I know enough, but I am not by any means trying to come off as an expert in anesthesia. You want to make sure that you're going to eliminate that pre or post-operative pain as much as possible during the procedure. So opioids, make sure we know that we don't have any intracranial pressures. They can decrease heart rate, increase temps in cats. You know, the usual culprits are going to be your morphine, your hydromorphine, your buprenorphine, or fentanyl. Now, when it comes to local blocks, this is where I am a true believer that these work. And what we're doing is we're really preventing conduction. You can use pretty much anybody in the cane family for blocks. There's some that are better than others. And we need to know that many of these family of drugs, especially bupivacaine, can actually have cardiovascular toxicity. So we don't want to get it into the patient's blood vessels. So we're going to talk about ways to eliminate that. Now, the advantages to using anesthetic blocks or local blocks is that we can reduce that anesthetic requirement. We don't have to do the old, universal sign for crank them up, right? We don't have to do that, because if that block is in place and it's working, we can maintain that patient on a much lower anesthetic rate. Now, I know that I can maintain patients with canine extractions, maxillary canine, mandibular canine extractions in pretty overall healthy teeth. Maybe they were fractured, but they weren't loose. And with the block, I can keep that patient at 1% ISO or even lower. So I know blocks work. And when I have that anesthetic rate lower and the patient's going to be pain-free when they go home, my owners are happier, okay? And the patient is also going to eat that evening. And that makes the patient feel much better too, or the client feel much better. Now, there are contraindications. You don't want to inject into really nasty infected material or tissue. We don't want to drag that bacteria into a deeper spot into the mouth. And there are sometimes some side effects. Some animals, because they lose their sensation when we do a block, they might lose sensation to their tongues and they might self-mutilate. If you've ever had a block on your teeth, I tend to talk with my teeth together until my block is worn off so I don't bite my cheek or my tongue. I'm going to teach you the way I do blocks now is really helps limit the amount of self-mutilation, and knock on wood, all the years I've been doing blocks, I've never had this happen. Okay. Another thing to think about when you are looking at preventing self-mutilation is how you recover your patient. Put them in sternal recumbency so their tongue is more in the normal anatomical location and not kind of hanging out the side of their mouth. Sometimes patients wake up and they're a little bit excited. Okay, they can't feel their tongue, they're feeling their face. They might need just a little bit of sedation to kind of help relieve that anxiety. So here's my warning. Although some experts advocate the insertion of the needle deep into the foramen, the way I teach this is going to be a less invasive technique, but it's also going to be less likely to cause nerve damage. So, or other damages to the body. So I am going to talk about just going to the edge of the foramen, and we're going to use a little digital pressure and gravity to kind of help us with that. Now, you don't have to go buy a beautiful, expensive syringe to do these. A 1 mil or a 3 mil syringe to size, depending on the size of your patient, works fine. I like 25 gauge needles primarily. There's occasionally times I might want to use a 22 gauge needle, maybe in a really large dog. But for the most part, a 25 gauge needle is sufficient. Now, I still have on here lidocaine. I rarely use lidocaine anymore, and we'll talk about why I don't do that. But I really do like the 0.5% bupivacaine. That is kind of my drug of choice. Now, I have here other options. And the reason I'm not a big fan of lidocaine is because it does have a very fast onset, but its duration is very short, okay? Other drugs you can use are going to be mepivacaine. I know we had some shortages in the bupivacaine for a while, so people were looking for other options. Mepivacaine is another one you could use. Ropivacaine is another one. We used to mix lidocaine and bupivacaine together with the thought that the lidocaine would have fast onset, but the bupivacaine would make it last, you know, longer. And really the research now shows that when we combine the two, it actually decreases the efficacy of either one of them. So I stopped mixing them probably 12 to 15 years ago. I just don't do it anymore. I do just bupivacaine by itself. So looking at that, now there are many different dosages out there, and I don't want you to think that this is the only one you can use. So use your research, figure out what dose you want to work with. When I'm looking at, sorry, my dog's going crazy. When I'm looking at bupivacaine, 0.5%, in a dog, I'm going to use 2 mg per kg. A small dog, I might even use just 1 mg per kg. In a cat, I use 1 mg per kg. Now, granted, the dosage could be much higher than that, but I kind of keep it low. And per site that I'm injecting in a small breed dog or cat, I'm going to go about 0.01 to 0.015 mils per site. I don't give a whole lot, and I have found this to be very effective. In a large animal, larger dogs, I might go to 0.03, maybe even up to 0.5 mils per site. So we're going to give a little bit more in those areas. Now, if you want longer effectiveness, so as I mentioned earlier, buprenorphine can be added to the block, to the bupivacaine, to increase that duration. Bupivacaine probably ranges anywhere from 8 to 12 hours by itself, depending on which textbook and reference you look at. But if you want to extend that longer, you can add 0.003 mg per kg to your syringe of, you can add buprenorphine at 0.003 mg per kg to your Marcaine, bupivacaine. It will actually increase that dosage and increase that longevity of that block. There are some reports out there of adding dexdomitor or dexamethasone at 1 to 2 micrograms per kg. Some people really like it. That I haven't seen any studies yet that really show effectiveness. It is being shown effectiveness in humans and rats, but not necessarily in dogs. But it is, you know, something that's being used anecdotally. And I know a lot of people are using Nocita. I haven't really used that drug, so I'm not going to talk about it here, but I know some people who have had really good success with that drug when it comes to blocks. And remember, I said that these are cardiotoxic. We want to make sure we don't get into the blood vessel. It's not a fun time. I've had it happen to me in a dental chair, and it's not fun to go into AFib because your doctor got the anesthetic in your bloodstream. You want to make sure you aspirate. Now, I say 3 times on here prior to injecting. We just want to make sure that our needle, the bevel, isn't up against a blood vessel or the wall. So I usually rotate and aspirate at least once or twice. All right. I just want to make sure that I'm not into the blood vessel. If I draw back and I get blood in my syringe, I'm actually going to take my needle out and get a new syringe, because I'm not going to know next time if it's kind of old or new blood, right? And then I'm having someone, while I'm doing the blocks and for 5 minutes or so after the block is placed, really closely monitoring my patient and watching to see if there's any reactions. So here's a step-by-step. I draw up the dose and I put a new needle on it. So I didn't mention this, but when I had that picture of the needle and the syringe, I actually also have 2 syringes because it's kind of a, don't jinx myself by only having 1. And then I have a lot of needles there. And I use a new needle each time I do an injection. So I've drawn up the dose. That needle has gone through that rubber stopper. I'm going to put a new needle on because I want a really sharp needle when I'm doing these blocks. I don't want to take something dull and kind of drag it through some very friable tissue. I'm going to insert that needle into the injection site. I'm going to aspirate and rotate at least once or twice. And then I inject. I'll use digital pressure and I'm going to monitor. So let's talk about some of the blocks. Now, if you have a patient that you can't get to where you want to place the block because of infection or even deciduous teeth, yes, I block pulling baby teeth, I might do what we call a field block. And this is just where we're going to inject around the individual tooth into the gingiva, and we're trying to just infiltrate that tissue around there and kind of giving them just a local block right into that spot. They're not going to last as long, but it is something to just kind of help a little bit. An infraorbital block, there's 4 blocks we're going to talk about in here, and I'm going to tell you there's 2 that I use more frequently than others. Infraorbital block, infraorbital foramen is going to, the way I do it, is only going to block the canine and incisor teeth. All right. It's not going to block anything past the canine. I don't use this very often because many times I have to block more teeth than that. The infraorbital foramen is located just above the upper third premolar. You can always palpate it for the most part on our patients. It's kind of, we can palpate that ventral margin. I use a 25 gauge needle. Don't worry, I have a picture coming up. I insert that into the opening of the foramen. I don't go into the foramen. I just go to the edge of it. And then I'm going to go ahead and inject and hold my finger pressure for, I say 1 to 2 minutes. In reality, we're happy if we make it 30 seconds, but we lift that nose up a little bit and let gravity work. So let's show you here. There's the infraorbital foramen, and I've got my needle just parallel to the maxilla of the animal. And I do this because I'm getting a little bit more support this way. I'm not going to, kind of jiggle my needle by accident. I'm going to go just up to the very edge of that foramen. I don't go into the foramen because there's blood vessels in there. There's nerves. You don't want to lacerate a nerve doing this. And there's sometimes an eyeball right there. So I just go up to the very edge. And I'm going to aspirate, rotate, and inject. Another view, some people actually have shown me coming up this direction, right in front of that foramen. And you'd want to have that bevel facing into the foramen when you're ready to inject, but it's just another option to do this block. And then I'm going to create kind of a bleb. It's a technical term, but a little bleb of the medication. I'll remove my needle, put a little digital pressure and lift that nose up a tad just to kind of help that medication get into the foramen. But remember, it only does the canines and incisors. Now, I don't use this very often on a cat. If I do, I'm going to come up kind of from the bottom, like I showed you on that last view, because in a cat, there is only a few millimeters between that foramen and the eyeball. And nobody wants to make the phone call that, Mrs. Jones, we got an excellent block on your cat, but the eye, it's gone. So we don't want to do that. So I rarely, if ever, use an infraorbital on brachycephalic dogs and or cats. I actually love the Caudal maxillary block. This block is going to block all of my maxillary teeth on the side it's administered. And it's going to be the landmarks are basically caudal to the maxillary second molar. And there's going to be the same bundle of nerves that runs into that infraorbital foramen is going to be running back through here. And that's what we want to do, is we want to bathe that nerve bundle in the medication so that it can actually anesthetize it. Now, there are a few things to be cautioned here. And just to show you that nerve bundle, you can see the red lines going, kind of showing you where it's going on here. It's not as fancy and drawn out as the ones you're going to see in the textbooks, but just to kind of give you an idea of what we're doing. And there's a lot of different ways to place this block. And if you had 10 different people teaching you nerve blocks, there's 10 different ways. I bring my needle in kind of at an angle like this. It's basically so that the needle crosses over the cusp on that first molar. And I'm going to go into that kind of soft, it's really a technical word, but soft squishy area back there. And I'm going to go in and then I'm going to angle my needle a little bit more. So it's going a little bit more medial. And I'm just going to go in a couple millimeters. aspirate, rotate, inject, take the needle out and just have a little pressure there. It's going to block that entire quadrant. So this is the nerve bundle we're looking at up here. Okay, here's my molar teeth. And what we're doing is just kind of blocking this. Now, a lot of people will come straight up. I know people who bend the needle, come up behind that back molar. Any way you get it in there is fine. But I just like this approach. I'm a little bit less worried about puncturing an eyeball when I kind of come in at this diagonal and rotate in a little bit and block that nerve bundle. Now the middle mental block is going to be done on the middle mental foramen, and this is on the mandible, but it only blocks my mandibular canines and incisors. So it's very difficult, if ever, to palpate the middle mental foramen. It is located below the rostral root of the second premolar. There's always a frenulum there that can make it really difficult to locate. And to be quite frank, I don't even use this in cats, because that foramen is about the size of a pinhead, and I'm not even going to try to do this in a cat. But there's the middle mental foramen, and there's a couple different approaches you can do. You can come in straight like this and just go to the edge of it again, aspirate, rotate, create your bleb, remove the needle, digital pressure, and elevate that chin a little bit so that the drug can actually work into the foramen. Another approach, I tend to do this more frequently, where I'm using the canine just to kind of steady things a little bit, going to the edge of that foramen, the same thing we just talked about. But again, this only blocks your canines and incisors. So I love the the mandibular nerve block. And I think this is one that's probably my favorite to do. It's also known as inferior alveolar foramen. Now there's two methods to this. One is intraoral, one is extraoral. I was taught back when I learned to do blocks that the extraoral was safer. You're going to do a transcutaneous approach, but this is going to block all of my mandibular teeth on the side it's administered. So intraoral, you're rarely, if ever, going to, again, palpate this foramen. And you can't enter it because it's kind of pointing to the back of the animal. Unless you take the jaw off, you can't get into the foramen. So you're just going to go to the edge of it. Many people do this. They kind of pull the tongue off to the side. They go right in there and aspirate and inject. I actually, oh, there's just the foramen, sorry. I prefer doing it extraoral. And what I'm going to do is actually I have my finger in the animal's mouth and I can see my finger kind of down underneath the jaw, kind of through the skin. And a lot of times you're going to have that notch down there on our dogs. That's where I want to inject. Now we have a notch on us. If we don't have the notch, I just drop a plumb line straight down from the lateral canthus of that patient's eye, straight down. And that's going to be approximately where that foramen is. I actually come in almost 90 degrees, and then I walk that needle up underneath the jaw, and I actually scrape along the bone with the needle. It's the one time you get to scrape the bone with the needle. And I have my finger in there, not because I want to stick myself. I pull my finger away a little bit when I'm actually moving the needle, but I want to make sure that I can feel the needle on the medial aspect of the jaw, of the mandible. I don't want to be accidentally injecting on the buccal aspect of it or the outside aspect. So I want to make sure that I'm in the correct area. I'm going to aspirate, rotate, inject, create that bleb, remove the needle, digital pressure in that area, and maybe even tip the chin down a little bit to try to help gravity work forward. So this is really what I'm trying to do. Coming up right here beside it, I'm going to aspirate and rotate, and it's going to depend on the size animal, how deep you go with your needle. Now, when it comes to post-operative pain, now when I place these blocks, they usually take a few minutes to kick in. So usually as soon as I know we're going to do something to that patient, I'm getting those blocks on board. And then by the time my doctor is ready to do the extraction or whatever procedure we're doing, the block has kicked in. So just kind of get those blocks in early, because they do take, anywhere around 10 minutes to kick in when we're just doing buprenorphine, okay? Now, when it comes to post-operative pain control, you can use, again, I said butorphanol is kind of a weak option to go home. Tramadol is what we used all the time. We know now that that's really not going to be the most effective drug out there. Buprenorphine in cats, if you have the owners just kind of spray that onto the mucous membranes in the cat's mouth, it works great. We found out that even though we drew up the right dose in individual little syringes, none of our pet owners were actually giving it to their cats because they were afraid to. So we actually had buprenorphine compounded at a pharmacy down the road from us, and he made it into a transdermal gel that we could have the owners rub in the ears, and it worked really well for our patients. Other options in the hospital are going to be fentanyl CRIs. Trying to send home opioids can be very challenging, and we don't want to necessarily do that, but we can give these meds while the animal is still in the hospital. NSAIDs, I'm a big believer in sending home NSAIDs. You know, we want to make sure that we're kind of helping not only with the immediate pain with the opioid, but also inflammation. So we have our list here. Yeah, we can use, you know, roboxicam, or I can't even say the word, robenzacoxib on cats. Even, you know, acetaminophen and codeine in dogs has been reported to be very effective. You know, there's injectables, there's orals for acute pain. You know, just want to make sure you're giving what is going to be in the best interest for that pet. There's even some reports of using gabapentin as a pain management. I see I have a couple questions. I'm going to kind of get to those at the end if that's okay. Again, gabapentin is something we can use to help reduce those inflammation responses. It's going to inhibit excessive pains at the incisional or peripheral nerve injuries. So it works well when you're using them with an NSAID and an opioid, but make sure your pet owner understands that we may not have a pet who's responding really, or going to be kind of drowsy and tired after the effect, okay? So let's talk about a case report. Now, this is actually kind of an adjunct to all the pain medications we've talked about, and this is going to be the Assisi pain management system, or Assisi loop. Now, this is a patient that was seen by a diplomate in dentistry, and you know, I'm just going to kind of go through how this worked. This was an 11-year-old neutered male, domestic long hair, and he was presented to this diplomate for full mouth extractions because he'd had a history of gingival stomatitis. And if you've seen a cat with gingival stomatitis, you know this is painful, and there's really not much we can do. He had been managed on steroids for about 2 years. In addition to the steroids, he'd been on cyclosporin, opioids, chlorambucil. I mean, he'd been on everything, but this gingival stomatitis really just never got better. All right. So he was actually now coming in to have full mouth extractions because, you know, that's effective in about 80% of our times. Now, after they did this, they found out that even with full mouth extractions and confirmation of all of the tooth being removed with x-rays, he still continued to have inflammation and proliferation in, you know, caudally in his mouth on both sides. So they continued all of these different drugs, you know, and then they added to that the Assisi loop 4 times a day for 15 minutes. Now, they did discontinue Depo because the patient started having, you know, transient diabetes mellitus. So they did discontinue that. But they continued to put this patient in this, and I've got a picture of it coming up, but it's kind of a little lounge area for the cat to go in 4 times a day for 15 minutes. So just to show you what they did with this patient, pre-anesthetic blood work, you know, metatonidine, butorphanol, atropine was given to this patient, propofol to effect, maintained on ISO. Now, within 2 weeks with this patient, his swelling started to improve a little bit. The erythemia started to improve. He loved to be in his loop, especially with the catnip toy. Okay, he loved that time in there. Within about 4 weeks, the erythemia was almost gone, but the proliferation was unchanged. At 6 weeks, he had less than 3 millimeters of the erythema present, but his proliferation just did not change. However, this cat started gaining weight. He started eating again. He started acting like a cat. He seemed to really feel much better and doing what he needed to do. Over time, he continued to gain weight. And over time, all of those meds that we talked about on that previous slide were discontinued. So this is the Assisi Loop Lounge. And I'm not sure every cat's going to lay in there as comfortably as this one is, but the loops are kind of in the bottom. And we know that this technology is going to actually help heal the patient as they lay in there. And it takes, 3 to 4 times a day. And it's not, excuse me, an instant recovery. It's going to take time over time for that patient to heal. So basically, in summary, pain management is mandatory in my book. We need to use multimodal pain approach every which way we can to block that pathway. Blocks, to me, are inexpensive. They're extremely easy to master, and the effect is so significant. Now, I used to say that, blocks are kind of like hand grenades, close is good. You don't really want to hit the nerve. You want to just bathe that nerve in the anesthetic. And I believe that the benefits of pain management outweigh the risks associated with analgesic drug administration. So I'm going to come up here. I know we had a few questions. Oh, I guess there's just one. Susan, for the infraorbital foramen block, is it placed from the mucosal surface or the cutaneous? I actually do mine from the mucosal surface. Okay. There are people who actually will show it coming cutaneous, but I go, lift the lip and go in on the mucus side of that. Hope that helps you. Any other questions? How quick does windup happen? It can actually happen fairly quickly in a patient. We want to prevent it. So, if a patient comes out of anesthesia and they're irritated and restless and kind of noise, making a lot of thrashing around and things, they're already starting to get into wind up. So I like to start that preemptively and keep that medication on board so we don't have to have it happen. Okay, thank you, Susan. I'm glad that helped you out. Sorry, it's hard to show that when you're just using a skull. Did you say you compounded transmucosal buprenorphine? How did you dose it? Oh boy, that has been many years ago, so I appreciate that question. We dosed it at the same dose recommendation that it would have been had it been the oral administration in the mouth. But we just worked with the compounding pharmacist down the street from us, and he had done a lot of compounding for us for other things to be transmucosal, thyroid medications and things like that. So he would, make this into the gel, and then we would just have them, he had it marked on there how much in the syringe, how much they could put in each time. I'm sorry, I don't know the exact dose for that anymore. One of the things we really liked about this, though, is that we didn't have some of the controlled substance offages, discrepancies in the records, because every time you're drawing up those individual syringes, you're going to have a little bit. I know they say you can't have hub loss, but you do. And we would just have the patient or client go pick that up at the pharmacy, and we'd show them the first dose, and then they would go back, and it really wasn't in our practice, but it would be something. It's basically the same dosage that I would do if I was using it from the syringe. Sorry, I don't have a better answer for that. I'm coming down here to another one. Can we go over the block sites again, where they're located? Yes, I will go through that for you in just a second. Maria, I'll be back with that. I'm going to answer Maria Hancock's question about what if you don't have bupivacaine available. Lidocaine is going to work. It's just know that it's not going to last very long. Question is, if they don't have bupivacaine available, can they apply lidocaine block before and after the procedure? You're not going to get that much longer block. It's better than nothing, but just make sure you don't overdo the entire day's dosage for that patient. Okay, so that's kind of one of the major things you want to look at. If you can't get bupivacaine, look to see if you can get ropivacaine or mepivacaine or something else to use that's going to have a longer lasting lifespan for the block. Diane, did you say 0.01 on the slide, or is it 0.1 of the bupivacaine? It's 0.01. And that's mils in a site. Okay, that's per site. Now I don't do both the caudal and the infraorbital. If I do the caudal, it's blocked everything on one side. We'll go back to those slides real quick to help you guys out. Okay, hold on just a second. Okay, whoops. Don't get seasick here as I do this, guys. Okay, just to refresh here on the dosages, it is going to be 0.1 mils per site for dogs and small cats. I go up to 0.15 and 0.13 mils per site. Now the dosage is 1 meg per kg or 2 megs per kg. So don't confuse the megs per kg to how much I'm actually giving in that site. And then you wanted to see the locations. This is going to be the infraorbital area right above the third premolar. It is really helpful if you have a skull in your practice to kind of get an idea of where these are at. It's usually just directly above the third premolar maxilla on the maxilla. Or you can come up this way. You don't want to go into this on a cat or brachycephalic because you'll lose an eye. The other block is going to be kind of coming up directly. I use that kind of cross my needle over the cusp of the first molar and just kind of rotate into that softer area back in behind the notch that is right here. And this is that nerve bundle, again, that we're just bathing in that bupivacaine. There's the infraorbital, or excuse me, middle mental. And there's just another approach to that. That is right below the second premolar. And again, it's very rare will you ever really palpate this, because remember they have a really pretty thick frenulum there, and I don't even try this on a cat. And then the back is either to come in intraorally. I have heard reports if you do intraorally, you're more likely to have tongue numbness and self-mutilation. So I always do the extraoral version where I'm coming in almost 90 degrees, walk up underneath that jaw. We drop a plumb line straight down from the eye, the lateral canthus of the eye, so we know where we're injecting at. Okay. Any other questions? Oh, there's a few. Okay. All right, I guess those are the ones I've already answered. Are there any other questions? If not, I thank you guys for being here today. If you have any questions, you want to email me. My email was on the very first page, and if you need to get that, I'm sure Assisi can supply that to you. I do have a article that was written that has all these pictures and more information in it that is going to be, available to you. Is the loop effective for acute postoperative pain? Maybe not for acute. Okay, acute, you're going to probably want to use an opioid, but it is going to be for more of the long-term healing of that. Which side is down for the left mandibular block? I got to lay on my side for a minute. It would be the right. If I'm doing the left mandibular block, my patient's laying on his right side. Okay. Thank you, Christina. I appreciate that. There are loops available for dogs. So there are different size loops. I don't think there's a lounge. That little lounge that I showed you could be used for a small dog. Smaller dog could be in there, but they do also have loops available for larger dogs.